Hi class, today I'm going to be discussing the motor activity log. The motor activity log is a semi-structured interview to assess arm function. The age range it targets is adults 18 to 64 and elderly adults 65 plus. It should be noted, however, that there is a pediatric version of this assessment. Most of the pediatric research completed is with children with CP. The length of time to administer this assessment is approximately 20 minutes. The motor activity log is highly researched and often used in practice. There has been an abundance of research with populations who experience hemiparesis, including individuals who have had a stroke, CP, and more specifically used in research of clients completing constraint-induced movement therapy and non-invasive brain stimulation. It's also globally used with versions of this assessment used in Brazil, Turkey, and Germany, for example. The ICF domain that this assessment focuses on is activity and participation. More specifically, the assessment focuses on the movement of the affected upper extremity during 30 functional tasks. For example, some of the items are opening a drawer, picking up a phone, getting out of a car, wiping off the kitchen counter, or opening the refrigerator. So as previously mentioned, the MAL uses two 6-point ordinal scales. The first being the amount scale and the second being the how well scale. Before beginning, it is important for the clinician to remind the client that they should answer the questions based on what they actually do, not on what they think they could do. Also, it is important that the clinician explain the difference between the amount scale and the how well scale. It may be helpful to print out these two scales for the client to look at. Here is the amount scale. It should be emphasized that the amount scale is the measure of how much the affected upper extremity is used. So 0 indicates not used, 1 indicates very rarely used, 2 indicates rarely used, 3 indicates half pre-stroke, 4 indicates 3/4 pre-stroke, and 5 indicates same as pre-stroke. Next is the how well scale. The how well scale measures how well the client believes that they used their affected arm. 0 indicates never, 1 indicates very poor, 2 indicates poor, 3 indicates fair, 4 indicates almost normal, and 5 indicates normal. Now we will discuss how to administer the motor activity log more specifically. So the first thing you're going to want to do is to inquire about the use of their more affected arm. You could ask, considering your activity during the past week, did you use your weaker arm to, and then state the activity. For example, turn on a light with a light switch. If the client responds no, you should ask why. There's a list of possible no responses. The client's response may be, I use the unaffected arm entirely, someone else did it for me. I never do that activity with or without help from someone else because it is impossible. For example, combing the hair for someone who is bald. Or I sometimes do the activity, but I did not have the opportunity since the last time I answered these questions or within the past week. Or lastly, this is an activity that I normally did on my dominant hand before the stroke and continue to do on my dominant hand now, for example, handwriting. So, if the client answered no for the item, you would want to document this in the if no why section, and then you would not move on to the amount scale because the client does not use the affected arm. However, if the client answered yes, I do that activity with my affected arm, you would then move on to the amount scale. You would then ask the client what amount they think they used their affected arm during that specific activity. You should verify the client's response and then record their answer. You should then ask the client to refer to the how well scale and ask them how well they believe they do this activity with their affected arm. Once you have documented how well the client believes they complete that activity, you should move on to the next item. Within this version of the MAL, there are 30 items. However, it should be noted that there are different versions such as the MAL 14 and MAL 28, which have different numbers of items. You should also be aware that there's no total score for this assessment, and that rather you can use this as a pre and post test to compare scores or just get a general idea of how the client feels they are functioning and how well they use their affected upper extremity. So now I'm going to insert a video of me administering just the first 3 items of the motor activity log. My name is Monica. I'm going to be your occupational therapist today. So today we're going to be discussing how well and how much you use your affected arm in your daily life. I'm going to be asking you some different questions, and I want you to respond using these 2 scales, the amount scale, which refers to how much you use your arm, and the how well scale, which refers to how well you think you used your arm. Do you understand?
Yes.
Perfect. So within the past week, did you turn on the light switch while using your affected arm?
Yes.
What is the amount you think you used your affected arm?
3.5.
All right, and how well do you think you used your affected arm to turn on the light switch?
4.
In the past week, have you opened a drawer using your affected arm?
Yes.
What is the amount that you used your affected arm?
2.
How well did you use your affected arm while opening the drawer?
1.
Within the last week, did you remove an item of clothing from a drawer using your affected arm?
No.
Why is that?
My roommate helps me get my clothes up.
All right, so now we're going to discuss the psychometrics or clinometrics of this outcome measure. Normative information is not established. However, reliability, specifically test-retest reliability, was overall excellent, with the Howe scale having a reliability falling between 0.6, which is a questionable reliability, to 0.9, which is an excellent reliability, and the amount scale having a reliability falling between 0.7 and 0.85, which is an acceptable and good reliability, respectively. Inter-rater reliability is not established. Internal consistency was overall high. The amount scale had an excellent consistency of 0.8 to 0.88, and the how well scale had an excellent consistency of 0.91. For criterion validity, there was excellent concurrent correlation between the how well scale and the stroke impact scale hand function scores. There was also excellent concurrent correlation between the action arm test and the motor activity log, an adequate concurrent correlation between the how well scale and the accelerometry. When comparing clients and caregivers' scores within a research study, there was excellent concurrent correlation between the participants' how well score and the caregivers' how well score. There was also excellent concurrent correlation between the participants' how well score and the caregivers' amount of use score. Also, there was excellent concurrent correlation between the participants' how well score and the accelerometer recordings. Lastly, there was no established construct validity, content validity, or face validity. So lastly, I'm just going to discuss some factors to consider to avoid bias. So we must consider if our client has a cognitive impairment. However, we can give the caregiver the motor activity log testing, and the client should not be present, and it is recommended that the caregiver lives with the client. Some other factors to consider include a low socioeconomic status, so they may have limited access to some of the items that are discussed, such as a refrigerator, getting in and out of a car, and various items such as that. Also, gender roles and preferences. So some of these tests are related to cleaning or dressing, and especially for our elderly clients who have more strict or traditional gender roles, these might not apply. And then lastly, we must consider that it's not appropriate to administer this to a client who has not been in the community since their stroke. So this is a chart here from Rehab Measures that further explains this idea. It is not recommended to use with someone who's in an acute care setting, and it is recommended for inpatient, skilled nursing facility, outpatient, and home health. And this is because of the type of items that we are asking the client to report about. They would not be exposed to those in an acute care setting. Thanks for watching. I hope this was informative.